If you run a physical therapy practice, your clinical staff likely spends a significant portion of the day on tasks completely unrelated to patient care. They are chasing prior authorizations and navigating a paperwork maze that eats up hours of highly specialized time. Look at this chart mapping the latest data from the American Physical Therapy Association's 2025 survey. As prior authorization wait times stretch toward 2 weeks, the toll on staff becomes clear. 91% of physical therapists report that administrative burden is directly causing their burnout. This delay impacts the patients directly. Because the paperwork wall is so high, the survey shows an 83% patient abandonment rate. In 8 out of 10 practices, patients are stopping treatment simply because they cannot wait any longer for approvals. To fight back against these insurance delays, 3 out of 4 practices have hired extra non-clinical staff specifically to manage payer requirements. This creates a difficult cycle. Practice owners pay a premium for local administrative control, yet wait times still stretch for weeks while profit margins shrink. Preserving the image of in-house control often comes at the expense of clinical outcomes and revenue. It is time to evaluate why the traditional local hiring model is failing and what the alternative looks like. The problem is rooted in the complex physical therapy episode of care. A patient touches multiple systems and requirements before their first treatment even begins. This flowchart illustrates the workflow. A referral arrives, insurance eligibility is verified, prior authorization is submitted and tracked, and the plan of care is certified, all before scheduling can be finalized. If a local staff member is distracted by a phone call or a walk-in, verification and authorizations sit untouched. When either of those steps stall, the entire patient episode stops. Compounding this is a difficult labor market. Outpatient practices face a 13% vacancy rate, while local candidates are frequently lured away by hospitals or urgent care centers offering higher pay. This presents a choice: continue competing for a limited pool of local talent, or transition to the emerging standard of dedicated virtual medical assistants, or VMAs. Because the administrative chain is so fragile, relying on a rotating local workforce often leads to systemic bottlenecks that a dedicated remote team avoids. Hiring in-house involves costs far beyond a base salary, including benefits, payroll taxes, office space, equipment, and the expense of employee turnover. A fully loaded in-house admin costs $60,800 per year. Compare that to Staffingly's dedicated virtual medical assistant at $1,800 per month, or $21,600 annually. That is a 64% cost reduction, saving your practice $39,200 per position every year. Adopting this model means giving up physical, shoulder-to-shoulder oversight of the front desk. However, that 64% reduction in overhead provides the capital needed to survive tightening insurance margins and a shortage of qualified clinicians. Beyond the costs, there is a major difference in timing. Recruiting and training a local hire typically takes 60 to 90 days. A dedicated Staffingly VMA team integrates with your EHR and begins processing tasks within 48 to 72 hours. This speed eliminates the repetitive cycle of training new staff on your specific documentation standards, only for them to leave for other opportunities. To make this transition successful, a practice must standardize its EHR protocols so a remote team can execute them without ambiguity. While rapid deployment relieves administrative pressure immediately, it requires a clinic to move away from ad hoc habits and into standardized operational protocols. Outsourced VMA models incorporate AI automation to elevate performance levels above what traditional office labor can achieve manually. This diagram shows smart routing. AI analyzes incoming tasks and assigns complex insurance work to specific specialists, preventing front desk bottlenecks. The team also uses AI voice neutralization during live calls, ensuring patient interactions sound professional and clear from any location. Security is handled through enterprise-grade infrastructure, with certifications for HIPAA, SOC 2 Type 2, and HITRUST to ensure patient data remains protected. Using this model means prioritizing rigorous service-level agreements and consistent performance over a local, conversational office atmosphere. The combination of AI tools and high-level compliance gives smaller practices an operational edge and a level of data security that is usually too expensive to build internally. The current data makes one thing clear: hiring local talent is no longer the most efficient way to solve administrative overload. This checklist shows the ideal profile for outsourcing, growing practices where therapists are distracted by paperwork. For them, a 64% cost reduction provides crucial financial leverage. Conversely, low-volume, cash-pay micropractices relying on a physical receptionist should stay in-house. Adopting a VMA structure requires a shift in mindset, from managing people in a physical room to managing outcomes and specific performance metrics. Physical therapy exists to help patients move without pain. Every hour spent on administrative delays is an hour taken away from that primary mission. In a clinic without administrative friction, therapists remain fully focused on the patient in front of them, leading to better clinical results. Removing that paperwork wall stops the revenue leak and helps patients finish their treatment plans rather than dropping out in frustration. Instead of competing for local administrative staff, you can leverage dedicated remote teams built to handle the insurance maze for you. You can see how this integrates with your specific practice by starting a risk-free 30-day pilot. It is a direct way to reclaim your time and your clinical focus.